Well, happy New Year, everyone. I think we will go ahead and get started, and I'm sure others will continue to join as they are able. Jen Specht here, and delighted to see those of you who could join. We are continuing with the Best of San Antonio 2023 with part 2 today. And I know we've got speakers lined up, including Dr. Simons and Dr. Gwynn and Dr. Hunter and Dr. Nair. But in the sake of time, I will go ahead and get started. I have just a couple of updates that I wanted to share. And the first is what was added on as a late-breaking abstract on the results of the ANAVO 120 study. And I've been practicing very hard on my pronunciation of inavolisib, and so I'm sure I will still mess it up, but here we go. So this is a press release that came out on Monday, December 4th, with San Antonio starting on Tuesday, and Genentech announced positive results of a phase 3 study in inavolisib in combination with fulvestrant and palbociclib. And thanks to extraordinary work by the organizing committee of San Antonio, this was a press release on Monday. And let me see if I can get my slides to advance. On Friday, it was a podium presentation by Dr. Javari. And so again, this is a smaller phase 3 study that evaluated the combination of inavolisib, PI3 kinase, selective PI3 kinase inhibitor in patients with PIK3CA mutated, hormone receptor positive, HER2 negative metastatic breast cancer. So as we know, we have a need for additional therapies in the endocrine space, and particularly targeting the PI3 kinase pathway, which is one of the most frequently altered pathways in hormone receptor positive, HER2 negative breast cancer. Inavolisib is a highly potent and selective PI3 kinase inhibitor. We know that these agents can be effective, although toxicity and continuing to maximize and optimize the therapeutic index is an important step. And so Dr. Javari, and again, I should preface these slides are entirely Dr. Javari's that she presented during the meeting. But this is a phase 3 study which evaluated in a randomized fashion inavolisib in the combination with palbociclib and fulvestrant as first-line therapy for patients with endocrine-resistant PIK3CA mutated metastatic breast cancer. So here's the trial schema of ANAVO 120. Again, the key eligibility criteria, these are patients with PI3 kinase mutated, hormone receptor positive, HER2 negative breast cancer. These were patients, this was their first treatment in the metastatic setting, and patients were selected based on the presence of PI3 kinase mutations, and those were determined and assessed primarily, almost I think exclusively, by ctDNA testing, so blood testing to detect the mutation. These were patients that were really endocrine resistant, either primary or secondary endocrine resistance, where they had had disease progression either during their adjuvant endocrine therapy or within 12 months of completing adjuvant endocrine therapy for early stage breast cancer. No prior therapy for advanced disease. And specifically, given what we know about the potential for hyperglycemia with targeting of the PI3 kinase pathway, patients had a fasting glucose of less than 126 and a hemoglobin A1C of less than 6. So really screening out patients who had prediabetes or frank diabetes. The randomization is shown here, 325 patients planned, and they were randomized 1-to-1 to receive inavolisib as an oral agent daily with palbociclib and fulvestrant versus a placebo. The primary endpoints are shown here. This was a progression-free survival by investigator assessment with secondary endpoints of overall survival and others shown here. Stratification factors also shown here with visceral disease, endocrine resistance, whether it was primary, secondary, and region of the world. The enrollment period was very recent, December of 2019 until September of 2023. So there were still a number of patients actively on study and had just completed enrollment. So this is the first report of this study. In terms of the statistics, again, primary endpoint was investigator assessed PFS. The patient disposition, again, from Dr. Javari's presentation, 161 patients randomized to the Inovo arm and 164 to the placebo arm. At the time of the assessment, which I think was late September, their data snapshot, 42% of the patients on the Inovo arm remained on treatment, whereas 49% of the patients on the placebo arm remained on therapy. And you can see again disposition and completion of fulvestrant and palbociclib for both groups. In terms of the demographics, a couple things to point out here. Patients again were selected for this trial based on really development of endocrine resistance, so early relapse on after adjuvant therapy. You can see highlighted here that there were a number of Asian patients that were included in this multinational study, and a very small number of Black patients enrolled to this trial. These were patients that had good performance status. There was a good mix of pre and postmenopausal patients. And you can see again that patients on this study almost all had received primary chemotherapy. I think I'll show that later. But there was a high proportion of patients with visceral disease in the lung and liver. And then endocrine resistance, I highlighted down here, was determined using the ESMO guidelines. So that primary resistance was relapse within the first 2 years of adjuvant endocrine therapy, and secondary resistance was relapse while on adjuvant endocrine therapy or within 2 years or within at least 2 years, or relapse within 12 months of completing adjuvant endocrine therapy.
I'm doing my job.
And so in terms of prior therapy, important to point out here, almost all patients, or 80% plus of patients on both arms, received adjuvant chemotherapy or neoadjuvant chemotherapy. And interestingly, a high proportion of patients on this study, again, it was multinational, had received tamoxifen as their adjuvant endocrine therapy, a proportion with an AI only, and then a smaller proportion of patients who had prior a combination of AI and tamoxifen. What you'll see here is that the role for the use of adjuvant endocrine, or excuse me, of adjuvant CDK4/6 inhibitors in this patient population was exceedingly small. So these are the results shown by Dr. Javari. This is the primary objective for progression-free assessment, progression-free survival with investigator assessment. And you can see a pretty early and profound separation of the survival curves in favor of those patients on the receiving the Inovo. And they show, again, this is the first assessment, or this is the first report at a median and a short follow-up of only 21 months. But you can see a stratified hazard ratio of 0.43, which is statistically significant. I think it's important to see that there's a pretty early separation of the curves favoring the Inovo. I won't show all of these are key subgroups in the forest plot, which demonstrates pretty consistent benefit across most of these of course, in most of these subgroups. You'll see that, again, maybe a slightly greater advantage for patients receiving tamoxifen, but again, it's a relatively small study with 300 and some patients, and these are all very small subgroups, so take those with caution. But again, demonstrated benefit regardless of primary or secondary endocrine resistance. With regard to overall survival, again, cautions, this is really early with a median follow-up of only 21 months, but you can see that there is separation of these curves favoring the inavolisib with a stratified hazard ratio of 0.64. But again, this is premature, not mature data that is not yet meet the pre-specified boundary for overall survival at the time of this analysis. In terms of response rate, you can see pretty substantial improvements in both overall response rate and clinical benefit rate favoring the Inovo. And then, all important with regard to toxicity, these are the adverse events according to treatment group, both based by grade 3-4 and all grades. And you can see that neutropenia, again, with palbociclib and fulvestrant, is pretty uniform across both arms of the study. We see, as has been reported previously with PI3 kinase inhibitors, we see stomatitis and mucosal inflammation, which is higher in patients receiving the Inovo. However, the grade 3-4 was noted to be relatively low. Similarly, we see and expect to see hyperglycemia with these agents, and that was indeed shown in this study as well. But again, the frequency of high-grade hyperglycemia was on the lower side compared to some of the other trials using these agents. However, I would also make the point that these were patients that were highly selected, that were essentially non-diabetics.
Okay.
Rash was seen a bit more frequently in the Inovo arm as well. So in terms of AEs that led to discontinuation, you do see, again, a higher rate of discontinuation of treatment related to adverse events in those patients receiving the inavolisib. And then in terms of the summary and conclusions from Dr. Jafari, the addition of inavolisib to palbociclib and fulvestrant demonstrated a statistically significant and a meaningful improvement in progression-free survival, nearly just doubling it from 7.3 to 15 months, with a hazard ratio of 0.43. Overall survival is certainly trending in a very encouraging direction for this combination as well. And as we always say, there was a manageable safety profile, albeit, again, we haven't completely escaped for sure the side effects of hyperglycemia and stomatitis and rash. And so this was thought to be a potential represent a potentially new therapeutic option, particularly for this very high-risk group of patients with primary or secondary resistance. Dr. Hope Rugo gave the discussion for this paper, and I just put in a little bit of context from what else we already know in terms of the role for PI3 kinase inhibitors in this patient population. And you'll recall the SOLAR-1 trial, which was a slightly larger study that included patients with both PIK3CA mutant as well as PIK3CA wild type breast cancer. Again, a somewhat similar patient population with a high proportion of visceral disease. These were patients, again, you can see the split between primary and secondary endocrine resistance. And in terms of the progression-free survival, there was a benefit associated with the addition of alpelisib to fulvestrant in the second-line setting for patients who harbored PIK3 mutant tumors with those that are wild type showing a more diminished benefit. And so we have approval of alpelisib based on these results in the second line setting, recalling that the study we just looked at was in the very first line setting. And then additionally, we have recent data from capivasertib in the Capitella trial, and I just took some snapshots here. Again, this is a phase 3 study that showed that the addition of capivasertib seemed to improve progression-free survival, particularly in patients with AKT pathway-altered tumors. And so this is now also FDA approved, although I'm not sure if we've been able to get any patients in our population started on it in the second line setting. This trial, interestingly, had the same issue with lack of Black patients enrolled. Again, this is taken directly from Hope Rugo's discussion, where she looked again with all of the caveats of cross-trial comparisons, but just to look a little bit at the adverse event profiles of these 3 different compounds. Specifically, would note that there were eligibility criteria for each of these studies was different, specifically with regard to hyperglycemia. And so these need to be taken with some caution, but we, again, I would say, have not yet overcome this particular challenge with this pathway inhibitor. You can see that there's some differences in diarrhea and stomatitis across the 3 compounds as well. And again, for the vast majority of our patients, as Hope Rugo pointed out, many of whom are pre-diabetic or frankly diabetic, the issues with hyperglycemia are likely to be substantially magnified from this highly selected clinical trial population. One of the things that I like to take away from this was I think we're getting better at really defining different levels of endocrine resistance. And I think ESMO's done this, and this was a slide taken from the Aurora initiative, looking at the impact of these definitions of endocrine sensitivity on progression-free survival in the first line setting. And I think that these actually could become more useful tools. I don't know, clinically, I think we know these when we see them. We know the patients that are highly endocrine sensitive who take who maybe don't even, who take a long time to progress even on single agent monotherapy with endocrine therapy versus those that are that progress very quickly. And I think thinking about designing and thinking about how we write our trials to maybe do a little bit better job of structuring and capturing this, particularly given these data that show that these classifications are meaningful with regard to outcomes. And then again, a slide here showing the progress that's been made in this pathway. I think we're getting closer, and continuing to refine the therapeutic index is important. I would just point out over here all the way to the right that the mutant selective PI3 kinase inhibitors are coming quickly. We are looking forward to opening one of these trials. The OKI-219 study in the PICTURE trial is in our pipeline to open at our center as well. And then in terms of next steps, I think that, clearly this pathway is incredibly impactful for patients with hormone receptor positive disease. However, the toxicity continues to be a challenge. I think as has been discussed, it's incredibly important that we continue to work on including a broader patient population in our research studies. And for inavolisib, I think we're going to need a bit more time to look at some additional long-term follow-up. As well, and as well as thinking about how can we do a better job in the real world of managing these toxicities in terms of stomatitis and the hyperglycemia and rash. I'd like to just point out, give a quick shout out to our portfolio. In the second line space, we have the Victoria trial open, and this is evaluating gedatolisib, which is a combined mTOR PI3 kinase pathway inhibitor. And we were involved in some of the early phase 1 studies of this compound, which I think just got accepted for publication, which is great. But we saw that there was pretty substantial activity of this compound in patients with hormone receptor positive and more refractory metastatic breast cancer. And so the Victoria trial is a little bit of a complicated design here, but is looking at the addition of gedatolisib to palbociclib fulvestrant and in the second line setting. And so we're actively screening patients for participation in this trial. The very last thing I wanted to do is quickly mention and give a shout out to our very own advocate and expert, Linda Weatherby, who presented this poster. And this is a completely different topic, guys, but one of her passions, which is really understanding more about postpartum breast cancer. Linda presented this with Jenny Borges from University of Colorado, and is doing really great work to not only engage and increase knowledge around the idea of postpartum pregnancy and those risk factors, but also working on designing potential therapeutic targets through translational research. And so I realize this is really hard to see on the slide, but I would encourage you all to take a sneak back and go look at her poster. So I will stop share here, and it looks like I can see Lynn is on and Tasha's on. Maybe Lynn, Dr. Simons, are you okay to take the mic next? And then maybe Tasha afterwards?
Yeah, absolutely.
Great.
Can you hear me okay? Okay. I'm just gonna share. Can you see okay?
Yes.
Okay, great. Okay. So I'm going to be covering some of the updates in the immunotherapy realm that came out of San Antonio. I have no conflicts of interest or financial disclosures, so I'll just dive right in and highlight 4 of the trials that were really spotlighted at San Antonio. Of course, lots of interesting work spotlighted in the posters as well, but for the sake of time, I'm going to focus on 4 of the more interesting trials that got spotlight sessions. So the first one was looking at results of Checkmate 7FL, which was a study looking at neoadjuvant chemotherapy plus nivolumab in patients with estrogen receptor positive, HER2 negative primary breast cancer. And specifically, the study was reporting out biomarker results. So it was presented by Shireen Loy. And so just a quick overview of the study design. It included patients with ER-positive, HER2-negative breast cancer that were T1C to T2, N1 to N2, or T3, T4, N0 to N2. And then it could include grade 3 patients with greater than 1% ER expression, or grade 2 with ER 1 to 10%, and then standard sort of other inclusion criteria. Patients in the study were randomized 1-to-1 to one of two arms. In one arm, they got neoadjuvant paclitaxel followed by AC in combination with nivolumab. In the second arm, they got, again, neoadjuvant Taxol followed by AC with a placebo. And then following surgery, they got nivolumab with endocrine therapy versus placebo with endocrine therapy. And then patients were followed up long-term. And again, this study is really looking at, that they presented is really going to be looking at biomarkers. So that's what we're going to spend the majority of the time talking about. But results looking at PCR were previously reported, which did show improved PCR with this regimen. So the first thing that the study looked at and was stratifying was PCR based on PD-L1 status with nivolumab compared to placebo in combination with the neoadjuvant chemotherapy. And what they reported and found here was that the benefit with nivolumab increased in patients who were PD-L1 positive, and that seemed to be dependent on CPS score. So in particular, patients who had a CPS score of 10 to 20 or higher seemed to derive the most benefit. The next biomarker that they reported out was TILs, and essentially any TIL resulted in improved response, and that was true for both PCR as well as residual cancer burden. And then higher TIL burden also seemed to correlate with greater benefit, but really any presence of TILs, those patients had better responses to the nivolumab, which fits biologically with what we know about TILs. Then they also looked at ER expression and found that patients with low ER and PR expression essentially had better responses. So patients that looked more like our traditional triple negative patients tended to have a more robust response to the nivolumab. In this, they used a cutoff of less than 50% for their ER status, but particularly patients in the 1 to 10% group seem to have benefit. And then they also looked at and strategized by Ki-67. There was no real association between nivolumab response and the Ki-67 index. So key sort of takeaways from this, previously reported data showed statistically significant improvement in PCR when nivolumab was added to neoadjuvant chemotherapy. That was their primary endpoint, and again, has been previously reported. A higher magnitude of benefit was seen in patients who were PD-L1 positive. And then as reported in this analysis, the benefit of nivolumab on PCR and residual cancer burden was really greatest in patients with tumors who had a higher CPS score, TILs greater than 5%, though any TIL presence was beneficial, low ER status and/or low PR expression. And then, as I already mentioned, again, TILs and any presence of TILs was increased. PCR was seen, and then higher PCR rates were also observed in patients with CPS scores of greater than 10 or 20. And really the key takeaway from this was that we really still need ongoing analysis and studies to determine which patients will optimally benefit from the addition of immunotherapy, particularly in our estrogen receptor positive patients. We really still need a lot of tools to stratify which patients might benefit most from these strategies. The next trial that I was going to share is the Keynote 756 trial, which was a phase 3 study of neoadjuvant pembro plus placebo with chemotherapy, followed by adjuvant pembro or placebo with endocrine therapy, again, in early stage high risk ER positive HER2 negative breast cancer. And so again, this was a study where they'd previously reported PCR rates, and they had reported improvement with the addition of pembrolizumab in terms of PCR in patients with high risk, high grade, early stage ER positive breast cancer. Here they were reporting out data from their subgroup analysis. And so as an overview of the study design, this was again for patients with locally confirmed breast cancer. Here it looks like they did sort of stratify that this would be ductal carcinoma. And then patients could be T1C to T2, N1 or N2, or T3 to 4, N0 to 2. And these were patients who were treatment naive. Similar to the last trial, they were randomized in a 1-to-1 fashion to one of two arms. The first arm, patients received paclitaxel followed by AC or EC in combination with pembrolizumab. And then in the second arm, they received, again, AC or Taxol followed by AC or EC in combination with placebo. And then after surgery, again, similar to the last trial design, patients could receive pembro with endocrine therapy or placebo with endocrine therapy. And this study looked at PCR, but also had a dual endpoint of EFS. The EFS data is still not mature, so hasn't been reported. And I think people eagerly await that data, but was not yet available. So this was just key sort of takeaways from their subgroup analysis. They looked at by stage, nodal involvement, PD-L1 status, and ER status, and essentially found that there was essentially benefit of pembrolizumab regardless of stage. That benefit was persistent. Same with nodal involvement. For PD-L1 status, again, the higher the PD-L1 expression, it seemed to be the greater magnitude of benefit. And similarly, with ER status, the higher the ER status, the lower the magnitude of benefit, or the lower ER patients seem to derive more benefit from the addition of the immunotherapy. They also looked at geography, which I didn't show here, but again, benefit persisted regardless. So I just highlighted there with the red stars that the magnitude of benefit seemed greatest in patients who had lymph node involvement, had low ER expression, and had higher PD-L1 expression. So again, in this trial, CPS scores of 10 to 20 seem to have the most, or higher, seem to have the most benefit. And they also looked at residual cancer burden after surgery and found that the addition of pembrolizumab seemed to shift more people to a lower residual cancer burden. So you can see that about 35% of patients shifted to having a cancer burden of 0 to 1. So this was just a nice slide I found from Dr. Laura Hubbart's talk where she did an overview of the sessions. And I thought this was just a nice comparison looking at these two trials side by side. So both of these trials were phase 3. They were both placebo randomized control trials looking at neoadjuvant followed by adjuvant PD-1 inhibitors in combination with neoadjuvant chemotherapy. Looked at a very similar patient population for estrogen receptor positive HER2 negative breast cancer. Key differences, of course, one was using pembro, one was using nivo. And then just a note that Keynote 756 enrolled a much larger number of patients. So they enrolled 1,278 patients, which was essentially double that of Checkmate. Again, pretty similar inclusion criteria, some slight difference in terms of grade and stage, but overall fairly similar patient characteristics. And then both studies were stratifying by nodal status, PD-L1 status. They did use different PD-L1 assays. So KN756 was using 22C3 CPS and 7FL was using SP142. And then in their biomarker analysis, they also used 28.8 CPS. And again, both were powered to detect PCR, but KN756 or Keynote 756 was also powered to detect differences in EFS. Again, we have not yet seen the data presented from that. So this was previously reported data, but both trials have shown a benefit in terms of PCR with the addition of the immunotherapy agent. And then as shown in these subgroup analyses that were reported at San Antonio this year, that benefit really seems to be greatest in our patients who are PD-L1 positive, have low ER expression, and have TILs present. The next trial I was going to review was the Impassion 030 trial. This was a trial looking at the addition of atezolizumab to adjuvant chemotherapy for stage 2 and 3 triple negative breast cancer. And so, again, this was looking at adjuvant treatment. And at the time the study was conceived, I don't think we had data from Keynote 522. So obviously our practice and way we use immunotherapy and the triple negative space has shifted in the last couple of years. But the way that this study was designed was essentially patients would get induction chemotherapy, followed by a maintenance arm if they had a response. The chemotherapy regimen was AC or EC and paclitaxel, and then patients got atezolizumab in combination with that. In arm B, patients got only chemotherapy. So this was looking at stage 2 and 3 triple negative breast cancer. It was a large study with 2,300 patients, and the primary endpoint was DFS in the intention to treat population. Secondary endpoints they looked at were disease-free survival in PD-L1 positive patients, in node positive patients, and then they also looked at overall survival, relapse-free survival, and distant relapse-free survival. And so essentially the takeaway is going to be is that this was a negative study and that futility was ultimately declared at their planned interim analysis. They basically didn't find any difference and they crossed this futility boundary. And so their median follow-up was 25 months, but essentially no significant difference was noted with atezolizumab plus chemotherapy versus chemotherapy alone in terms of disease-free survival. Similarly, there was no benefit seen regardless of PD-L1 status. There was no significant difference. About 71% of the patients were considered to be PD-L1 positive. And then similarly, there were no major differences in overall survival in the two groups. So essentially, the takeaway was that results do not support the addition of atezolizumab to adjuvant chemotherapy in patients who've undergone primary surgery for early triple negative breast cancer. And again, I think, a limitation or consideration with this is obviously, regardless now, we are now primarily in the stage 2 to 3 triple negative space doing the Keynote 522 regimen for patients with stage 1 and 2 disease. So finally, the last trial I wanted to spotlight was the KeyLink 099 study, which was looking at pembrolizumab plus olaparib versus pembrolizumab plus chemotherapy after an induction phase of treatment in metastatic triple negative breast cancer. This was for locally recurrent or inoperable or metastatic triple negative breast cancer for patients who had not been previously treated and had confirmed PD-L1 status. Primary endpoints were progression-free survival and overall survival in the intention to treat population. And then secondary endpoints were PFS and OS based on PD-L1 status and also BRCA mutational status, as well as safety data. So for the study design here, patients received carboplatin and gemcitabine as induction chemotherapy with the addition of pembrolizumab. And then following treatment, they were randomized in a 1-to-1 fashion to receive maintenance therapy with olaparib and pembrolizumab versus continuing on chemotherapy with pembrolizumab. And so essentially, they found that with the addition of pembrolizumab and olaparib together, that there was no significant improvement in progression-free survival when compared to chemotherapy. Similarly, no significant differences in overall survival. What they did find was that there was a lower incidence of toxicity in the group that received olaparib plus pembrolizumab compared to chemotherapy. And so in terms of treatment-related side effects, you can see that for grade 3 to 5 events, there were 91 events in the pembro plus chemo group versus 44 in the pembro plus olaparib group. So much less grade 3 to 5 toxicity in that group. And fewer patients needed to discontinue pembrolizumab plus olaparib as well. So while the study was powered to look at PFS and OS and found no significant benefit, I think as Dr. Rugo and Dr. Hurvitz have both mentioned, in this setting, I think it's still worthy of our consideration, even if it is non-inferior, but is getting patients a break from chemotherapy, so having similar outcomes, but patients are getting a break from chemotherapy and having less toxicity, I think that that's something that's still worthy of consideration. So ongoing work at how best to use these strategies is needed. Again, an interesting study that shows that there's maybe a potential strategy to spare patients some of the toxicity with this as a maintenance strategy. So those were key highlights. I think really the takeaway is that there's continued work, particularly in the estrogen receptor positive space, to really look at how to best use immunotherapies in that patient population and best define which patients will get benefit. And there was some really interesting work that came out of San Antonio looking at that. So those were main takeaways, and I think that's all I had.
Great, thank you, Lynn. And I would just add one more reminder that the SWOG is looking at the addition of durvalumab to neoadjuvant therapy for mammaprint ultra high risk patients. And I think as a group, we need to think about opening and participating in that trial to again address that question. So thanks.
Oh, and I would also ping that TILs still remain very important and are really important about how we think about these therapies.
For sure. I think Dr. Hunter, maybe Lynn can stop share and we'll hand the mic to Dr. Hunter.
Sure. Can you all hear me okay?
Yep.
Struggling to find my PowerPoint presentation. Just give me 1 second. Let's see. Sorry. You would think that I would have mastered Zoom by now, but
I don't know about you, but when you have like 10 screens open, it makes it a little confusing.
Exactly. Here we go. If I use presenter view, can you see, how do you see it?
Probably best just to, the presenter
Just
view
use the
gives us it small, the regular one is a little better for.
Got it. Okay. All right. So I am going to try to be very brief. I want to leave time for Will to present. I think he's presenting some pretty important studies. I wanted to talk a little bit about correlatives. There were a few interesting correlatives that had been awaited, and some other studies that I thought were perhaps more interesting than those highly anticipated ones. And then, so one of those is fragmentomics. I've included the exclamation point because I know everyone's excited about fragmentomics. And then because so many of the sort of really prominent studies at San Antonio have been presented, I thought I'd indulge myself a little bit and present what I thought was a really interesting study for metastatic breast cancer patients and activity. So, but I am going to try to be quite brief. So this was presented in the general
So
session.
Dr. Hunter, we're just not seeing your slides. I think we lost the screen share.
Oh, really?
We're seeing you, which is great.
I'm sure that's very nice for people. I wonder what happened. Just a minute. You seeing them now?
Yeah, we can. Yep.
Yeah, you're just in sort of the yeah, there it goes. Now you're in presenter.
All set? All right. So this was a presentation in the general session by Nick Turner, who, as I'm sure you're aware, is a very well-known British researcher in circulating tumor DNA. He had the privilege of looking at the correlative and biomarkers for the Monarch E trial. Which I think we're all fairly aware of the structure of. So Monarch E, which led to the approval of adjuvant abemaciclib in high-risk ER-positive HER2-negative breast cancer patients. So in the Monarch E trial, about 5,600 patients were randomized to receive either the CDK4/6 inhibitor plus endocrine therapy or endocrine therapy alone. And among that randomized cohort or sample, Dr. Turner's group selected a random sampling of those patients or of those tissue samples and a case cohort design. So a case cohort design is a somewhat uncommon design, but fairly common among biomarker trials that are sort of subsets of clinical trials, where there's a random sampling of the tissue and then additional cases. So in this case, patients who developed interval invasive disease-free survival events were included in the case cohort or included as cases. And so ultimately, it's basically just a random sample, but it's enriched for IDFS events. So ultimately, they enrolled 1,400 or selected 1,400 samples that were fairly evenly distributed among the abema versus the non-abema trial population. So they looked at essentially all sorts of different biomarkers, all sorts of different correlatives. They looked at whole exome sequencing, RNA exome sequencing, and then as well as oncotype, and then subtype analysis, and essentially and did some exploratory markers and correlated it to IDFS events. And essentially, and I'm just going to be very brief here because they really didn't find very much that was significant. Basically, it was abemaciclib benefit was fairly consistent across all the different molecular subtypes, across high and low risk oncotype scores. And then in terms of most prevalent genomic alterations, there was one possibly significant exception in terms of abemaciclib benefit. It wasn't clear that people with MYC amplifications did receive the same level of benefit, but that was that crossed the significance line as well. And so it was a fairly it was reassuring to know, I guess, that abemaciclib was consistent across all of the analyses that they did, but didn't really point to any future directions in particular, except possibly this MYC amplification. The second one that was presented was the PALACE trial, which, as we know, is sort of the sister trial to Monarch E, looking at adjuvant palbociclib in ER-positive, HER2-negative breast cancer patients. Again, a large group of patients and about 5,600, similar to Monarch E. FFPE tissue samples were taken and submitted to a central biorepository before randomization. And they looked at, similar to Monarch E, they looked at the intrinsic subtypes, looking at PAM50 and then whole transcriptome RNA analysis. And again, they really didn't find a whole lot that was significant. Pallis itself was not found to have significant benefit, or palbo, adjuvant palbo was not found to confer significant benefit among the population. And additionally, they tried to correlate high-risk patients, but they really found that there was a large proportion, larger than they had expected, of luminal A subtypes, greater than 70%. Not surprisingly, there was heterogeneity in outcome. It seemed like the luminal A folks showed the best outcome. Again, not surprising. And there was no significant association between invasive disease-free survival or treatment. And so really, there wasn't much to glean from this study in terms of future directions, at least as far as I could see. The thing that seemed encouraging about these studies was just that the volume of samples that was collected, it was actually in some cases was actually greater, I think, than the TCGA database for breast cancer cases. So this is the thing that I find to be kind of interesting and exciting about this is just the number of samples that are available for analysis is very high. So they have a very large biobank, but right now it doesn't seem to be yielding a whole lot in terms of significant correlations. So what I thought was more interesting, which was also presented in the general session, and this was the third correlative study. I'm not even going to attempt to pronounce this doctor's name, but he's actually an MD PhD fellow at Dana-Farber. So, and he looked at therapeutic exploitation of fusion RNAs in metastatic breast cancers. So, and so I'll talk a little bit more about this because I thought it was a little bit more interesting in terms of results. We know that the breast cancer genome displays high structural variation. So structural variation is basically anything in the genome that's technically, it's anything in the genome that anything from a single nucleotide variation to a chromosomal, aneuploidy. But I think it's a sort of arbitrary cutoff, but anything that's greater than 1 kilobyte, and so is counted, I think, sort of by general agreement as a structural variation. So so that includes sort of chromosomal variations and certainly aneuploidy, but also copy number variations and things like that. And so structural variations do occur quite a bit in breast cancer, somewhat surprisingly more in breast cancer than in other common cancers such as lung and colorectal cancer, prostate cancer. So breast actually demonstrates high structural variation. And so I'm just going to call him Nolan, I can't pronounce his last name, wanted to know how and why should we characterize and exploit structural variant breakpoints. So we know that there are sort of weak points in the chromosomes that are typically that we typically see as breakpoints when we see aneuploidy or when we see structural variation. And sort of the most common the most common example of that is like the Philadelphia chromosome, but there's obviously other ones. And so how do we exploit those breakpoints in breast cancer? And his thought was that fusion RNAs, he's looking specifically at RNA, so DNA expression. He is asking whether fusion RNAs resulting from the founder structural variation, in other words, the DNA variation produces an RNA or it is expressed in an RNA, can help in selecting biomarkers and targets for advanced breast cancer. So I thought that was an interesting question. And so he looked at highly expressed fusion RNAs in a cohort of around 400, around almost 500, so about 475-ish metastatic breast cancer samples, found highly expressed patient-specific fusion RNAs in about a third of the cases. And you can see here that in terms of subtypes, you're looking at high structural variation in basal subtypes, lower in luminal subtypes, although obviously there's more examples of those in the data. So and then, interestingly, there were a number of kinase and loss of function fusions. FGFR2, I think those of us who have sent off a lot of next generation sequencing orders. A lot of the more aggressive breast cancers, I think that we have seen often do show FGFR2 mutations. And so I found it interesting to see that that was one of the driving structural variations that they saw in addition to BRAF mutations. At San Antonio, in the molecular tumor board, it was interesting that one of the patient examples that they presented had a BRAF mutation like this, and was treated with a BRAF inhibitor, trametinib, I believe, and in addition, I think, to a MEK inhibitor, and had some degree of response. That's an interesting discussion, the tumor board discussion, if anyone has a chance to go and see it. So there were a number of kinase mutations, which we know can, those kinds of mutations can actually lead to a gain of function. And then there were also loss of function mutations. In summary, low frequency, the hypothesis is that low frequency recurrent gain or loss of function fusion RNAs may drive therapy resistance. Some of those may be druggable with FDA approved small molecules, and they currently are not found in current, or many of them may not be found in current testing. And then in addition, and I didn't mention this earlier, but there is an ESR1 fusion mutation that was found to be one of the most common mutation RNA or common fusion RNAs that they found. And it was always, not surprisingly, in the setting of treatment refractory disease. So that's that. I do want to speak very briefly. Oh goodness, I am going over. Very briefly about fragmentomics. I know that you're going to look at this and just be amazed at this poster. It's obviously very exciting. So just very briefly, what is the appeal? What are fragmentomics? What's the appeal of them? So one of the limitations of ctDNA, so circulating tumor DNA sampling, is that we don't get histopathologic data from it. So there's lots of talk about ctDNA or liquid biopsies replacing tissue biopsies. And currently, one of the real problems with that is that we aren't able to just do basic ER/PR testing. And so fragmentomics is the study of looking at ctDNA fragments and how they are cut up by DNA nucleases. And so we know that there are kind of somewhat predictable fragmentation patterns that are influenced by chromatin structure. Chromatin structure is influenced by the expression patterns of DNA. And so we know that there's greater diversity in fragment size when there's open chromatin, so when the gene is expressed, versus closed chromatin when the gene is not expressed. And there's some limited data that shows that those patterns in whole genome sequencing can be used to infer phenotypes. But there's really no practical or affordable way to do that in whole exome sequencing. And so this study looked at whether fragmentation patterns encoding just exon 1 of genes in fragmentation patterns in the coding exon, in other words, coding exon 1 of genes in targeted ctDNA sequencing panels can be used to accurately discriminate tumor type. And so they used a sort of classic machine learning algorithm where they looked at all of the data. They had a training set that they looked at trying to model the patterns that would be correlated with estrogen receptor positive disease. And then they had a validation set that they tested, and they really were able to discriminate surprisingly well. Here you see the ER negative line above the curve here in blue and the ER positive line in red. In addition, there was an assessment of ESR1 and CCND1 genes and they were able to predict here in the red ER positive and again in the blue ER negative. And so it really was quite discriminatory. So I found that to be quite interesting. It was not in the general session, but that was just a poster that I found to be fairly hopeful in terms of looking at ctDNA in looking at what we normally would think of as a result that's restricted to histopathologic studies and looking at it in ctDNA potentially. The last thing is that in totally change of topic, but a little bit just indulging my own interest in the metastatic breast cancer population, a European study looking at the effect of a structured exercise program on fatigue and health-related quality of life in patients with metastatic breast cancer. They called this the preferable effect study. They divided folks, very simple study, dividing people into an intervention group and a control group. And the intervention group, they provided with aerobic resistance and balance training with supervised exercise, 60 minutes twice a week, along with exercise advice. And then there was just sort of general exercise advice to the control group. Primary endpoints were the validated EO RTC fatigue assessment and quality of life assessment. They were looking for significant results, obviously, and then they had a few secondary endpoints as well in terms of anxiety, depression. And so the quality of life scores were significantly improved. They also had, I didn't go over the demographics here, but they had or the participation, but participation was about 3/4 of patients participated, and of the 18% or so that never came, or the quarter or so of patients that didn't participate, many of them didn't participate, or about 44%, I think, didn't participate ultimately because they had death or disease that limited them. So anyway, there were many. The results were quite significant in terms of quality of life and fatigue, which I found to be very encouraging. I think for my patients, being able to point to the data here in terms of encouraging patients to continue to exercise, to continue to engage in strength training in the setting of metastatic disease, I think is really quite. It's helpful, at least in my conversations with my metastatic patients. And then I liked the data that, or the little sort of examples that they presented of patients talking about their experience, talking about how it was a good opportunity to get out of the house and to interact with the coaches who were really motivational. And then a patient coming in saying that she's really quite ill, but when she comes in and exercises, she feels better. So I had hoped that I would not take up Will's time, but I'm afraid that I have.
Well, thanks everyone, and we can certainly, Will, you did a great job, and for those of you who were at the Benetera session, and Will did a fabulous presentation there, so we'll try to find time for him to continue to share that. We've got just a minute or so for questions. Very good. Information overload. Thank you all so much for presenting. Clearly, we need more time for San Antonio updates. Hope everyone has a good rest of day and stays warm. Thanks so much. And please join us. We'll be back next month. Thank you.